Hello, everyone. Welcome to our second kind of reorganization of the Houston Free Market Medical Association meeting. We're really excited to have you here. We've got a couple of great speakers. And what we want to do today, the problem has certainly, there are lots of recordings of FMMA national meetings and even some of our previous Houston meetings that tee up the problems in healthcare. What we want to do today is we want to tee up the solutions. We have the pieces in place here in the Houston market. Not every market has what we have, has this opportunity that we have. We have the opportunity here. We have the primary care solutions in place. We have the urgent care solution in place. We have hospital systems willing to participate. We have specialty doctors willing to participate. We have pharmaceutical solutions. We have green imaging. We have surgical solutions, Texas Free Market Surgery and other ASCs. So we have the major components in place to do some great things with affordable, high quality healthcare here in Houston that are not, where all the incentives are aligned rather than the way healthcare is delivered right now, where the focus by the big players in the space is really profit, whether that's hospital systems that are supposed to be not-for-profit, PBMs that are just the heavy middleman, or private equity-backed healthcare. Those are all problematic in the healthcare space, especially if you want a free market healthcare space, because the incentives are not aligned with those of the employers for sponsoring healthcare and of individuals who need to acquire healthcare. So I'm really excited about what we tee up here today. We've got Tony Dale, Dr. Dale, who is a physician by trade and practiced in Britain and has been working with the health sharing ministries in the United States for about 20 years, and now has a solution in place that works for both individuals and for businesses to provide a health sharing like platform, or it is a health sharing platform for high quality care. We have Carl Schuessler, who is a benefits advisor from Georgia. And I actually met him here in Houston, though, presenting to a group of advisors and employers. And Carl has done in the space where we're really thinking about reform-minded benefits advisors. Carl has some great case studies. He has provided some great solutions for real live employers, and he wants to tell us about that today. And so I'm excited to launch this. I think what we'll do is have Dr. Dale present, and then we'll have Carl present, and then we'll just talk about kind of how we see bringing these solutions together and how we further this effort. So Tony, so happy to have you here.
Well, thank you so much. I really appreciate the introduction, Cristin, and to all of you who are listening either now or will be watching this later. What we hope to be able to communicate today is that there really are already great answers in place for businesses that are feeling the pain, which, to be honest, is virtually everybody. We all know there's a problem. The issue is, are there answers? And so I'm going to share my screen. And with that, I'll then very quickly, if someone can confirm to me that you're now seeing a screen that shows a slide. And I hope
we see the deck. Yeah, I think you need to flip. Yeah.
Do you now see just the one slide?
Yes, sir.
Okay, perfect. Thank you so much. I love to start with this quote because I think it tells a story which is so self-explanatory in the sense that a picture is worth 1,000 words. Here's a writer who finds himself in hospital, subsequently writing about some of his experiences of the medical system. And he said this, he said, "We would like to think we have healthcare that incidentally involves some wealth transfer. What we actually have is wealth transfer that incidentally involves some healthcare." Now, that is a tragic comment from someone experiencing the healthcare system. And it kind of explains what I want you to see in the headline here of this particular article from Health Affairs. And that is the impact on the middle class of what's going on in the healthcare world. And this article, you may notice, was written in September of 2011. It would be every bit as true right now in November of 2021. And it says a decade of healthcare cost growth has wiped out real income gains for an average US family. In fact, if you look at the sort of highlighted section there in the first paragraph, whatever natural gain there has been in income, and not just in the 10 years that this article was looking at, but in the last 10 years, this gain was largely offset by increased spending to pay for healthcare. We have to find a way to grapple with the reality of the fact that healthcare has itself become a problem. The system itself is actually sick. So sick that when you look at the sort of newspaper headlines over the last 10, 12 years, when you look at the political sort of polarization of ideas, when whatever it is that you're looking at, healthcare always finds a way to bubble up to the top. And within healthcare, cost is the number one problem. And so we have to find a way to grapple with this. And the fact that people recognize that cost is the biggest challenge here does not mean that people necessarily recognize that there are any answers. But I want to suggest that what we already heard Dr. Dickerson say as she was introducing things is that Houston, particularly, along with a growing number of other cities, but Houston is kind of the epicenter in so many ways of American medical thinking. It's Medical City USA as you look at the hospitals and the centers of excellence everywhere across the city. And yet what is bubbling up from the grassroots when you have the opportunity to look is that all sorts of other things are emerging within the free market. She mentioned things like, direct primary care or free market surgery centers, or, things, such as I'm involved with in the medical cost sharing world. There are answers emerging. The question is, how do you apply these answers in the complexities of what every employer finds themselves having to deal with? I think that we really, as employers, we desire for our employees lower cost, better choice, preferably as little network as possible so that they really can exercise those choices for themselves. We want them to have access to care all the time, whether that's virtual or in person. As an employer, I'd love to be able to include, not only full-time employees, but part-time, because they need answers as well. And yet, as an employer, typically, I exist to make widgets or to provide this service or that service. I don't exist for the purpose of understanding and navigating healthcare as a business. It's just historically that I found myself, needing to be in a place of knowing how to help my employees. And as such, as the CEO of a growing company, or whether these companies are small, medium, or large, so many CEOs would love a way to get out of the healthcare business, even while still being very happy to help fund it, since that's the way that things have emerged within the American medical system. And there are now methodologies. Of course, there are self-funded approaches. There are approaches using the ICHRA, the individual choice health reimbursement arrangement, that makes it really practical and possible. Now, I'm sure we'll hear more from Carl on some of these things in a few minutes, after I've shared. But knowing there are answers, I want to try and give some pointers. And I would suggest a starting place is understanding that whether you're looking at direct primary care or virtual primary care, both of which are describing an approach where the patient has essentially unlimited access to, primary care physicians, family doctors, pediatricians, whatever it might be, who are there to take care of the core of care. It's having a really strong relationship with a physician or physicians who know you by name and who are engaged in every part of your care and who are interested not just in the medical component, but who understand that the financial component is also critical. Because one of the things we're going to see as I show you a couple of slides in a moment is that if we ignore the financial implications of the cost of care, then we may be damaging, severely damaging our employees or our family members or the others that we serve, even while we're taking care of medical things for them. And so the core of care, probably representing taking, I would say, approaching 75% of the medical interactions that any given patient is going to have during their life. That core of care comes within this primary care context. And in a context where people have unlimited access to that through a membership-based practice, which typically is costing less than maybe half the price of a cup of Starbucks coffee on the way to work, you know, maybe $2.50 a day, giving you this sort of access to a family doctor who knows you and is really interested not just in your sickness, but in your health, who's looking to bring you into a place of real healthy living, rather than just, as it were, planting the ambulance at the bottom of the cliff for when you've fallen off. Now, if you wrap around that, other approaches, on this particular slide, I mentioned Sedera medical cost sharing because that's what I'm involved with. But there are other approaches. And so I want to take us for a moment to look at a typical sort of quote. Because this was a quote, it was sent to me relatively recently by a small company. It actually happened to be in Atlanta, but it could have been anywhere in the country. And it compared their current sort of costs and what were some options for them as they looked at the future. And if you want to look at line 11 and 11:12 on this slide, the shocking thing about what this slide has to say from my point of view, and I don't know if you can see the cursor moving on your screen, but I put it on line 12, the first number there. This is the out-of-pocket maximum for a family, $16,000, as long as they're in network. Or if they're out of network, it can go up to $30,000. You know, that there probably are not 5% of the American public who can easily lay their hands on $16,000 or let alone $30,000. What we're effectively saying when we look at quotes that are like this is that what we're offering to people is a type of health coverage which is going to cripple them financially. And yet for 19 out of 20 employees, neither they nor their family member are going to have a bill that goes over $5,000. So they're functionally uninsured because they're going to have to pay, in this example, the first $16,000 themselves. I think as we understand that, we begin to understand why we have to find better ways to do this. Now, that same slide translated, if you look at the top half here, where it says current insurance plan, this was a small company. They actually had about 20 employees. Only 8 of those employees actually took anything. If you look at the top half, you're looking at what the quote they were seriously considering was going to cost. They had 4 employees only, 2 employee with spouse, 2 employee with children. That's 8 employees. The total cost for this plan, if you look at the total annual cost before the sort of line across halfway, $115,000 to take care of 8 employees and their families, where they had chosen for the family. Okay, now you look below the line at what something like medical cost sharing could do in that same context. And for those same 8 employees, instead of paying $115,000 a year, they'd pay the monthly shows as $2,000, so they'd be paying effectively $25,000 a year. meaning that this employer can now all of a sudden afford something for all of the employees, where the employee can afford it. You can see on the employee only line, under the middle halfway mark, the employee cost is suggested as nothing, because there are possible solutions here which and this includes, the price that you see down here includes these people having access to 24/7 direct primary care, right there within the market that they live in. Okay, there are approaches, and not only insurance approaches. We know people need a way to deal with major medical costs, but the insurance approaches are not the only one. They can be a good one, and in the hands of brokers who understand the options and the sort of thing that Carl is going to share with you in a moment, there are great answers within that world. But we need to understand that most of this is now outside of the typical framework, and it's beginning to access what the free market can offer, what direct or virtual primary care can offer, to see what things like the medical cost sharing approaches can offer. And so into that context, companies like mine have found themselves seeing a lot of awards because they're showing there really is an answer. And I think this is the critical point that I wanted to get across. We're not talking untested solutions. What we're talking about is real answers that can take care of the totality of what's going on in the health scene for our employees and our families. But it's also creating an environment into which we can take care of people at prices they can afford. So with that, I'm going to stop sharing my screen, and I'm going to hand back over to Cristin and to Carl.
Dr. Dickerson, you're muted, I think.
Thanks so much. And I would like to say that Green Imaging is actually a Sedera company. So that's how we're providing coverage for our employees as well. So Carl, glad to have you here. Again, Carl has a group of benefits advisors called Mitigate Partners that he works with nationally. He can partner up in a geographic region with somebody local who can really, bring the local flavor to a health plan, but that doesn't mean that he doesn't stay involved. We love having him back here in Houston when he comes. And so I want to introduce him as, one of the most innovative advisors I know. And we try to hang with those innovative advisors. Carl's actually doing a lot of what people are just talking about. And he's going to share a case study with us today that can demonstrate how a company can really change the way healthcare is delivered and the price tag at which it is delivered. Thanks for being here, Carl.
Oh, thanks. I appreciate the opportunity to speak to Free Market Medical. We've spoken in Dallas along with you, Dr. Dickerson and Dr. Dale. And I tell you, I can't believe I have to follow Dr. Dale. I called Dr. Dickerson earlier today and I said, if he goes first, I'm bailing out. She wouldn't let me, so I'm here. So y'all buckle up because it's going to be a fast ride. There's so much stuff. My problem is I believe more is less. Most people in America believe less is more. So I have real problems, and you'll see as we go. So for employers out there, does your annual renewal meeting look like this? What if we don't change at all? Something magical happens. Healthcare costs going up, profits going down, wages staying flat. What if it could look like this for you? What if a change would do you good, in the words of Sheryl Crow? Costs going down, profits up, and wages up. We're going to show you how that's possible. And we often get this from the C-suite when we're meeting with employers. Hey, this sounds really great, Dr. Dale, but I just don't know. I mean, what's the ROI? And hopefully you'll see the ROI when we get done here, what is involved. So key themes today. We're going to talk about employer-built healthcare, not insurer-built healthcare. We're going to talk about active management versus passive management. And we're going to cover that in a little more detail. I'm going to move quickly through here. And then we're going to talk about how you relocalize care and can make a difference for a community, because that's what it's about. Healthcare is local. It's not national. And it's certainly run by insurance companies. They're not in the healthcare business. They're in the money-making business. Make no mistake about it. And we were talking about building community-owned healthcare, not insurer-owned healthcare. And then how to maximize that local care team, like in Houston. How are you working with community pharmacists, physicians, hospitals, and the patient? We got to put the patient back in the center with the doctor. Right now, the patient's way over here on the periphery. And then the active manager of your plan can guarantee success, and you can offer 10 times the benefits for half the cost. I think we'll prove that overwhelmingly today. And then there's a way for you to have health insurance your way and on your terms. So I know the employers out there, every year they do the annual kabuki dance, as we say. Hey, you're going to have to make your benefits worse and your costs are going up. So then you're going to shift the cost of the employees and they're not happy. So it just doesn't work. So another thing that's really important, and a lot of people like myself and Dr. Dickerson or Dr. Dale are labeled as disruptors. How is doing the right thing considered disruptive? So we don't need to really disrupt healthcare. We need to correct it. And that's what I wanted to talk about. Today, we're only going to do one case study. We were pretty aggressive, and I generally get out over my skis a lot. So we're just going to talk about DeSoto Memorial Hospital. All of these case studies on our YouTube channel. The Gas Grilling and Club was shared for an hour at the Free Market Medical in Dallas. If any of you guys want that video, put it in the chat box, and I'll get Dr. Dickerson the link to it. Y'all welcome to have it. So let's look at DeSoto. This is a client we got in August of 2018. They're a 4-star CMS hospital. There's only 19 4-star CMS hospitals in the state of Florida, which is where they are. There's only 19. They're one of 4. The people up there at the top, the CEO, Vince Sika, Lois Hilton, Dr. Gross, a great, well-known direct primary care doctor, my co-founder and partner, Barry Murphy, and myself worked on all this together. They got about 157 employees, and they're a 49-bed rural community hospital in Arcadia, Florida. I would have never known if you had said, if Dr. Dickerson said, hey, Carl, you're going to go to Arcadia, Florida. I'm like, where is that? I have no idea where that place was, but Dr. Gross heard about our fair cost health plan, what we were doing. And Dr. Gross is who brought us there. That's how we got there. So here's Vince and Lois, again, key integral parts, along with Dan Hogan and Teresa Conley and other folks involved at the hospital. I'm going to play this quick video, and I sure hope that I shared sound. Dr. Dickerson, did I share the sound? Let me double check real quick, make sure I did that. Hold on real fast. Okay, I did. All right, let's see. We should be all set. Okay, I'm going to play this video and then tell you a little about it real quick.
We are self-funded here at this facility and have been for 30 years. Our premiums kept going up and up and up. We're a small 49-bed hospital, and we realized that we've got to do something.
When we met DeSoto Memorial, their health plan spend was about $2.2 million. We just wrapped up the first year, and the spend was around $990,000. So they saved $1.2 million, or 54%.
It's remarkable how much you can discount the price of something if you know you're going to get paid at the time of service.
What do we eliminate? The middle. We're going direct. That's how you save. It's direct to employer contracting. We negotiated a cash knee replacement price. That hospital was 70 grand. We got it for 25.
Direct primary care, where you just pay $65 a month, and that covers all of your primary care. And sort of the bundled cash payments are 2 prongs of things that we can do to actually reduce the cost of health care. We also have a program that's called the Medical Advocacy Program.
They walk you through the process.
It was kind of blowing my mind when they turned around and said, well, we'll do everything for you.
Getting them to the right doctor for the right quality, lastly, the right price, and at the right time. That's what this is about.
The less we have to spend on plan, the more we're able to put back into salaries, back into maybe additional benefits or increasing benefits.
As medical expense per employee per year. When we met them, it was almost $14,000 per employee per year. It's now right around $6,000.
Biopsy comes back, positive for cancer on the left side, and a week later, I was headed into surgery. As of today, all is well. I have gone through the process, an estimated cost of $42,000. What did I pay? Absolutely nothing.
And there was a lot of cost savings. So I actually got the bill 3 days ago, $31.76. An MRI is thousands of dollars if something were to happen to me or, God forbid, one of my family members. It's covered.
The opportunity to take this model that DeSoto has can be replicated across the country in all these rural areas. Absolutely.
Not having to sit around that board table this year and say, okay, how much of the increase is going to go to the employees out of their pockets? I was giddy. I was excited that we did not have to do that this year.
And we deserve that. I know I do.
The group that filmed that video, Patient Rights Advocate, we really owe them a lot. They're the ones behind all the hospital transparency legislation everyone is seeing. They're the ones that are behind that. They have been the key contributors to all that. Those videos, they heard about, thanks to Marnie Jameson Carey, Cynthia Fisher, Larry Santangelo, and Linda Bent. They heard about what we were doing in Florida, and they contacted us, and they came down and filmed 3 of our clients. One of them, Dr. Dickerson, and I have. I'm no longer working on what my partner is now. It's a school district, but they came down and filmed it. So we were so honored, and I think the video says it all. So I'm kind of done. No, I'm just kidding. I'll keep going a little bit. All right. So this book, Never Pay the First Bill by Marshall Allen. I hope if you haven't heard of it, you need to go get it. The only reason I'm showing it, I just want to show you, that's our quote we've always said, the health care is not broken, it was made this way. But this is his book, and it featured, he put a lot of and we were very honored, we're in there, and he talked about Gasparilla, the hotel, and he talked about DeSoto Memorial, and he also talked about school district, and also mentioned green imaging up there in the top right. If you see it, it's Dr. Dickerson and green imaging, Leanne. So this case study's been featured a lot of places around the country, and that's all I'm going to show you real quick. We had an event at Gasparilla that Dr. Dickerson attended back in June at the actual hotel, our client. And the session that DeSoto appeared on with Gasparilla was what flying looks like. They are out there way ahead of the curve. They're doing stuff that most employers in America hadn't even thought about. And you're going to see why it makes a difference. That's a shot of the hotel and where we had the event. And the clients are all up on stage with some of the FairCo partners. It's been featured at the Free Market Medical webinar series back in March. It's been featured at the Benjamin Rush Institute that puts the patients and the doctors back at the center of the healthcare. And 3 medical schools, I think, were in attendance. And it's been shared with the Florida Rural Health Association in August of 20 in front of a bunch of hospitals. And also in y'all's own state of Texas, in Austin, Texas, at the Texas Public Policy Foundation, we shared the story. And there's Dr. Dale's CEO of Sedera, Jamie Lagarde, right next to me. So anyway, it's been featured a lot of places. It's been told from a deer stand. I think Dr. Dickerson was at that Free to Care conference too. I didn't see any deer that day because I was running my mouth, so that wasn't very good hunting. But anyway, and it's been shared at Dr. Gross, who brought us to the hospital with nuts and bolts, and also in Cristin Dickerson's podcast. So here are the challenges that they faced. When we met them, it's the 4th poorest county in Florida. The per capita income was $25,406. They are about 32,000 people in DeSoto County, okay? So I just want you to get the framework. BUCAs were extracting millions from the community. BUCAs, for you folks out there that may not be familiar, you know, we love to throw acronyms around and show how smart we are. I'm kidding. Blue Cross, United, Cigna, Aetna, Humana, all the big 5 insurance companies. So this is a slide we've shown a lot. If you look here, all of these companies that are in red are in the top 20 of the Fortune 500. They're all middle people. They don't make anything. They're all right in the middle. And the companies that make the drugs, Pfizer, Merck, are way down the line, and they're the ones making the drugs. So I won't go on here because I can sit on this slide for 10 minutes, but that's the problem. And you want to take it to a monopoly board, there's what we got. You see who's on Boardwalk and Park Place. So anyway, I hope y'all found that humorous. I can't tell. These virtual meetings are tough. So they were passively managing their risk. And I'm going to talk more about what that means right now. They lost obstetrics in February 2018. Members have to drive an hour for deliveries in that community. It got taken away from them because of the affordability of it. Foreign medical spend. That's how much money was going away from DeSoto Memorial Hospital from its own employees. They were going other places for care, 79%. And we're going to talk about the significance of that in a minute. And their spend was $2.2 million. Drug spend of that was $482,000. So you have a framework of where it stands. We centered our programs around the deficiencies in healthcare we identified, and I don't have time to go through them. but embedded conflicts of interest, a lack of quality and pricing transparency, fraud, waste, and abuse, medical billing errors, the traditional PPO discount game, the pharmaceutical shell game, and the lack of information and data. That's what our whole program, Fair Cost Health Plan, was centered around. But what we did is we took those 6 deficiencies and turned them into opportunities. And that's what this is. And if you take these opportunities of your employers out there, you can make a huge difference for your members and both financial and clinical outcomes for everyone involved. So let's look at the solutions. We eliminated the middles. Y'all heard that, what we just said, you go direct. Let's look at that. We eliminated the middles and went from a BUCA plan to a fair cost health plan. This is healthcare simplified. A long time ago, I think Dr. Gross showed this to me. And that third party, y'all know who it is. It could be an insurance company. It could be a pharmacy benefit manager, a PBM, program billing millions, whatever you want to call it. So yeah, you can't see the problem. Of course you can't. You're looking through someone else's ears. So we said, eliminate the middles. And that's what we did. They were with a BUCA plan and we changed and eliminated it, and y'all have seen the results already. So active management, eliminating passive management quickly. This is traditionally what we run into in Houston. We have 3 or 4 Mitigate partners in Houston. This is what we see all the time. 99% of the time we walk in the door, we run into what we call a passive health plan. And it's what we call BUCA, Insure or Bill. Blue Cross, United, Cigna, Aetna, Humana, Insure or Bill. But it's easy, and a lot of employers like the easy button. Problem with the easy button is it doesn't work well. They're frustrated every year with their costs going up and benefits are getting worse. So we were frustrated with that, and we said we love Buckminster Fuller, a great inventor. So we built a new model that made the existing one obsolete, and that's where we came up with our fair cost health plan. So when you look at it, we deconstructed the whole healthcare system and rebuilt it brick by brick. And the foundation is just what Dr. Dale said, is based on direct primary care. Again, Dr. Lee Gross, the DPC doctor. A hospital is using a direct primary care doctor. A hospital owns physicians and they use direct primary care. That's how valuable they found it to be. And so Dr. Gross and Dr. Crouch in their office are great folks, and they've got a new physician down there, do a great job. So you end up with a custom employer-built, actively managed plan. All of these bricks should be present in an insurer-built plan, like what we just described, a passive plan, but they're not. So we went out and found the best of all classes we could find, brought them together, seamlessly integrate them on one roof into what we call the Fair Cost Health Plan. And that's how it came about, and it's a custom-built plan. We build it with you. The meeting with DeSoto Memorial, when we built this plan, went on October the 1st, 2018, from 1 in the afternoon to 6 in the evening, building their plan together. That's what you have to do. But I think it's worth it when you can save 1.2 million or 54%. It's kind of worth it, isn't it? Now, the employees, if you're an employer out there going, my gosh, that seems complicated. Not really. All the employee needs to know is where the front door is. One call, that's all, and that's all they need to know. But, you know, most people, including myself, no house is complete without a dog, and I got to stick a word in for my dogs, #1 in the country. Go dogs. So anyway, we utilize cost and quality transparency tool with direct cash pay. Why is that important? There is no transparency. What if we bought groceries the way we buy healthcare?
There are no prices on anything here.
Oh, believe me, some of it's pretty spendy. Whoa, that's really gone up.
Stop. I don't need both, just one or the other. It depends on the price.
Oh, that's called shopping. We don't do that here. Thank you for coming in. Your bill? Your version will be mailed to you in 30 days. Good luck trying to make some sense of it.
I'm sure some of you out there chuckling, and because I can't see you, I can't charge you. That is crazy. It's the only thing in America we purchase and don't know the price for 30 days. What's wrong with that picture? We got rid of that. DeSoto Memorial doesn't have that problem anymore. We were able to solve that problem, and now the employees are able to see what things cost before they go out and pursue the services. We're able to do that. We have nurse advocates that help. We have the CMS databases and the commercial databases we look at, and they identify good quality, cost-effective physicians. And we can talk all day long about that. Not all doctors are created equal, just like not all benefit advisors are created equal. By the way, if you work with a broker out there, any of you, a broker makes you broker. You need to find a benefits advisor. So anyway, in order to engage employees, your plan design's got to reward good decisions over and over and over. You have to design your plans correctly so employees make the right choices. So we found the data. We know how to get it in the hands of the employees. They've got support from nurse advocates. These are RNs helping them. And we believe in cash pricing whenever possible. Most hospitals will work with cash. They want that money right away. They don't get paid from the insurance company for 60 to 90 days. And again, the plan design's got to work. So here's an example of a hospital in Southwest Gulf Coast of Florida. A vaginal birth down there is $37,500. We were able to get it for cash for $6,500, paid 30 days in advance. These are the kind of strategies that are available to the employers out there. And it saves a lot of money. If you've been with a Buca, you'd have paid 19 grand for that same delivery. I told my dad that and he about fell out of his chair. I said he practiced OB/GYN for 48 years, so couldn't believe it. In order to engage employees for the third time, plan design's got to reward good decisions. So if the person decides to go their own way, the nurse navigator said, you need to see Dr. Dale, but they want to go see Dr. Dickerson and they don't approve of Dr. Dickerson, you can go see Dr. Dickerson, but your plan is going to work like it always did. But if you choose and follow the path of nurse navigator and see Dr. Dale, maybe a copay applies, deductibles waived. Those are some of the strategies you can do with your plans, and that's what DeSoto did. They offer 10 times the benefits for half the cost, incentivize their plan design, and this is still a work in progress. They had their own pharmacy internally now, but they were becoming their own PBM. We don't have time to visit that today. And here's some of the plan changes that we started with. We eliminated deductibles and coinsurance. Those numbers you saw, there's no deductibles for most of their coverage. They have 3 choices for hospitals. They can go anywhere in America, but in their region, here's what we did. If they went to their own hospital, there's no cost, no out of pocket. Why should there be? Remember, 79% of their claims costs were going away from their own hospital. So we fixed that with this. And then if they go out to, we have a friends and family group we've been able to work with and do some direct to employer contracting with the hospital. That's their deductible. If they go outside of that, they want to go to the Mayo Clinic, $1,000 deductible. That's pretty reasonable today. As Dr. Dale said, most of America is functionally uninsured. Not at DeSoto, and it doesn't have to be that way at your place of business either. We also, this is the most irritating thing for people like Dr. Dickerson. All this prior authorization and stuff that's being done and the red tape you walk through. If the people were pursuing care at DeSoto Memorial Hospital, we didn't require prior arts or pre-service. We didn't have that going on there. So that's another thing with customization you can do. Also, we relocalized care. We got neighbors talking to neighbors now. We're going back to Marcus Welby MD days. Got to watch the clock. The world's a big old place, guys. So what we did is we relocalized care and wanted to build a community plan. That blue dot right there is Arcadia. See, it's so small it doesn't even get a name on the map. And then we built out and are reaching the communities around it to bring on this type of plan. So when you look at it overall, it's kind of this. This is what we need to get back to, folks. Healthcare is local, not regional, not national, local. And you have to eliminate those counterproductive barriers that do not work in getting your people care. And in this model here, we've got everyone working together for the member and the patient. So we're taking it to the streets. We've been working with the city and the county and the school. We haven't finished this yet. COVID derailed us twice. Taking it to medium, large employers, having a direct dialogue with no regulation interference, and get the hospital out of the collection business. If the employees go to DeSoto, we're not going to have a deductible. Hospitals only collect 7% of that deductible and coinsurance money that many employers leave their employees with at the hospital. So we get rid of that, and we got neighbors talking directly to neighbors. We implemented direct primary care. We've covered it. You saw Dr. Gross. There's some information about Dr. Gross. He's an unbelievable partner, and he and Dr. Crouch have done so much. This is a quick study of the data since we've had the plan in existence. I want you to look at the DPC plan. They offer 2 plans, DPC and non-DPC. 70% take DPC and the others on non-DPC. Look at the cost per member per month differential. This is real legitimate data, folks. So if you're questioning direct primary care, I don't think you need to look any further. I'm not going to cover every line because I don't have time. Also, ACOs, that's the big buzzword with the Affordable Care Act, Obamacare. They generated $64 per beneficiary in 2019. DeSoto generated $2,420 per beneficiary. I'd say that's pretty dadgum good, thanks to Dr. Gross and all the great FairCo partners. So we implemented proprietary claim analytics. That's important. Just quickly, usually 10% of your population, drives 73% of your cost. And you have to identify those people. That's really important. Then the bottom 75 don't drive as much cost, but you got to identify them and you got to do something about it. And that's what we were able to do. We were able to look at different intervention opportunities, drug switching opportunities, the frequent flyers at the ER, who's going there. You can drill down into the data and look at this. Top 5 avoidable diagnoses. Diabetes, these kind of things. They were below the norm and one part higher than the norm. It's another client of ours. 121 didn't have an HbA1c test done. And 401 don't have HbA1cs less than 7%. That's a problem. You can find this out with the drill down we have. And here's one quick point to make. They were with a BUCA. I'm not at liberty to tell you which one they were with, but there were 66 people identified over 2 years of data that was studied before this case went in force, before we went live. In 3 months, 31 more people were identified on our FairCo health plan and data analytics in 3 months compared to 2 years of data from a BUCA. So that's how poor that data can be. And this is what we did. And they're in an integrated coordinated care program. We broke them into these categories. And now these people are getting care. Some of them have remote patient monitoring, the chronic care patients. Those are things that can be done. We dug into the opioids and we had an issue like most employers do. And I guarantee you have an issue now in your company because of COVID, 100%. We looked at this, by the way, Dr. Dickerson, this is amazing. We looked at the data again after the first year of on fair cost with Dr. Gross and Dr. Crouch. The DPC had such an impact that we didn't have an opioid problem anymore. That's what direct primary can also do for you. Almost done. We implemented integrated coordinated care. What is that? We have a system, Dr. Dickerson's seen this as well with some other cases, where all of the FairCo partners, all the bricks in the house communicate to take care of a member. I don't have time to give you stories, but I can go on and on and on all night long, like Lionel Richie, if you want to hear those stories. We have them. There's a ton of them. The care these members get is phenomenal. We do education meetings as also. That was a part of it. There's Dr. Gross and Dr. Crouch and Ann Horner, office manager there. Here are the results real quick. I'm over my time. Shocker. 157 employees. The challenges I covered with you guys earlier for our medical spend. The results, they saved $150,000 in their stop loss premiums. That's unbelievable. They incentivized their plan design, implemented DPC. They hired their first full-time surgeon in county history with all the money that was saved. Folks, that is significant. And their foreign medical spend reduced to 62%. And now I can report to you it's about 40%. All of a sudden, 40% more dollars are going back in their own hospital from their own employees, which is where it should go. It's a quality hospital. And that's their savings. And they had the second ever rate decrease in the history of the stop loss carrier. And so that was their savings. You saw it, 1.2 million. Just quickly to make a point, 3 months on the BUCA, administrative service only, that's their self-funded plan with a BUCA. That was their spend. 7 months on fair cost, that was their spend. That is significant. 2.5 times as many more months, barely spent more money. That's what happens when you eliminate the middles. And you already saw the savings. I don't need to bore you with that. It's 1.2 million, 54%. So impact on renewal, just finished the 3rd year. They've got 10 times the benefits for half the cost. I think we've shown. Rate decrease the 1st year. 2nd year had no rate increase. 3rd year had no rate increase, but their aggregate factors, that's the claims funding factors, went up slightly. Don't have time to give you Hannah's story. It's also been a feature of our Stop Loss Partners video, and outside the video, Lois Hilton, who unbelievable, this courageous employer and the leadership she's provided along with Vince. That's her comment. My only regret is we waited. That's in that video. She also said this: we've never seen a team come to the table and help us build our plans. That was a 5-hour meeting, folks, to build the plans. So it's a journey. It's got to be at your pace. No one can push you down the line. All it takes is a good advisor and a little courage. And I want to thank our courageous employers who took this step. But before I say that, at one time, Mount Everest was once unclimbable. Now there's a litter problem. There's literally bottles of oxygen, empty bottles all over the place. People around the country are doing it, folks. There's no excuse, and you can do it too. 100% possible. So in summary, we've chosen a different path forward, as you can see, actively managing our clients' health plan spend. We aren't brokers, we're population health managers. You've got to manage your population. That's what the name of the game is. Again, a broker makes you broker. Utilizing analytics, I think we've shown that too, what can happen. So let us Uber your health plan forward. It's Kodak. Path forward. Do you want to stay passive or active? And that's all I got. I appreciate your time. I know I went over.
Surprise, shocker, as Carl would say.
As I said when I got started.
Okay, well, thanks so much for presenting that. So much there bundled in. And again, I can make this recording available for anybody who wants to pass it along to employers in the area. I wanted to point something out. You know, we get a lot of questions about quality, and I just did some quick Google searches. And, you know, First Primary Care, which is a direct primary care solution here in Houston, has 5 Google stars. Houston Methodist Hospital is considered, you know, one of our flagship hospitals. Houston Methodist Primary Care Group has 3.7 Google stars. Next Level Urgent Care, which she not only offers urgent care, but they also have a subscription-based urgent care / primary care / durable medical equipment, and they include some x-rays and laboratories in that plan. She has that plan in place for employers. She's got 4.3 Google stars. Methodist Emergency Care has 3.0 Google stars. Texas Free Market Surgery, 5 Google stars. Green Imaging, 4.9 Google stars. Methodist Memorial Hermann Imaging Centers, 3.3 Google stars. So this is care people care about. You know, I give very few Google ratings. That's not something I go around doing. But for these players, I would give them 5 stars. They're really changing healthcare, and people are receptive to that. These are people who can now afford to get their kids care. You know, what we have happen all the time. Texas Children's Hospital here. You know, an MRI is thousands of dollars. We can't always do MRIs on children in the outpatient world, but we get about half of them done at, you know, a fraction of that price. An X-ray at Texas Children's Hospital can cost $900, and that's for the images alone, not the radiologist's interpretation. We can do that here for $75. So we have a great opportunity to change healthcare here. I'm open to any questions, and otherwise we will, you know, be back with you in another quarter and have more innovative ideas for how we change healthcare in Houston. Anybody have any questions? Well, if not, I'm going to close this, and I want to thank Tony and Carl so much for being here, and the rest of you for being here. And we look forward to the next meeting next year. Take care, everybody.
Thank y'all. Is everybody off now, or everybody still here? Some people still here? Just the group?